Hello everyone, my name is Kevin and I'm doing my doctoral work under Dr. Godavarty. And today I'll be discussing some of our work on a comparison of oxygenated flow patterns between controls and DFU subjects in response to breath holding. Now, before I start, I'd like to go over a little bit on, a little background about diabetic foot ulcers. So diabetic foot ulcers will affect up to 34% of diabetics at some point throughout their life. Shown to the right over here is the Wagner ulcer classification system commonly used to assess them. If left untreated or poorly mismanaged, DFUs will eventually deepen and lead to gangrene of the foot. However, even without gangrene, the association between DFUs and amputation is high. More than 50% of all non-traumatic diabetic amputations are due to DFU infection, and overall, 85% of all diabetic-related amputations is due to a DFU in itself. What more, recent research even suggests that DFUs are independent risk factors associated with premature death. DFU loans have a 30% mortality rate over a 5-year period, which bumps up to 50% when any kind of amputation is present. Hence, wound healing is critical towards the health and longevity of diabetics with foot ulcers. Now, shown right here are the 4 main stages of wound healing. After wound onset, there's going to be inflammation to prevent infection, followed by proliferation of new media, and then the remodeling of the new media. Interestingly, hypoxia initiates the wound healing response, and among other roles, oxygen is crucial for bacterial defense, angiogenesis, and collagen remodeling, making oxygen crucial at all stages of the wound healing process. However, while hypoxia will start the healing process, prolonged hypoxia stalls it, and often will stall it at the inflammatory phase. Meaning that the monitoring of the oxygenated perfusion to DFUs is critical for wound healing success. Now, 2 modalities have commonly been used to assess perfusion in DFUs: transcutaneous oximetry and laser Doppler flowmetry / imaging. Transcutaneous oximetry is oxygenation-based, but can be time-intensive and can only assess discrete point locations in the peri-wound. Laser Doppler-based techniques can provide real-time area assessments of perfusion, but only in terms of blood flow velocity, not oxygenation. Hence, real-time area assessments of oxygenation can provide additional insight into the oxygenated flow of DFUs. And in our laboratory, we have developed a near-infrared optical scanner to assess real-time tissue oxygenation changes across an area. So the objective of this work that we're doing right now is to dynamically image and assess the differences in oxygenated flow patterns in the feet of DFU and control subjects as a potential biomarker for monitoring wound healing. This work was broken down into 2 sub-studies, and in study 1, we'll be looking into if breath hold-induced oxygenation changes are synchronous in the dorsal and plantar side of the foot and controls. And in study 2, we're going to assess if the oxygenated flow patterns in healing and non-healing DFUs cases differ from controls. So moving on to study 1, we utilize breath holding as a stimulus to induce tissue oxygenation changes because the breath holding mechanism prioritizes brain oxygenation through 2 very useful means: bradycardia of the heart and peripheral vasoconstriction of the limbs. In literature, it's been shown to require as little as 10 seconds to produce a bolt or blood oxygen level dependent signal in the brain. And in our own past work, we show that we capture breath hold-induced oxygenation changes. For both studies, we utilize our near-infrared optical scanner, or NIROS. NIROS is a continuous wave non-contact device that utilizes several multi-wavelength LED near-infrared or NIR packages to illuminate the image tissue regions. The diffusely reflected near-infrared signals from the tissue is optically filtered through a long-pass filter before being focused onto a near-infrared sensitive CMOS camera. This IRB-approved study was conducted at FIU with 3 control subjects, imaged thrice or 3 repetitions, on the plantar and dorsal side of the foot for a total of 18 measurements. We utilized a 2-minute-long paradigm consisting of 20 seconds of breath holding, and we imaged each subject at 1 Hz of world resolution. From the 2D near-infrared images, we calculated the optical density maps at each time point and then applied the modified Beer-Leonard law to produce spatial temporal oxygenation maps in terms of oxygen saturation. Now, since each pixel on our spatial temporal maps assesses the oxygenated flow changes at that particular image tissue region, we have to develop a technique to concise it down and make a more clear assessment. So from one of the spatial temporal maps, we selected a region of interest and discretized it into subregions. Each subregion was averaged individually and across time to produce 25 oxygen saturation-based trend lines. One trend line representing the overall flow pattern observed through the paradigm was selected as a reference. Now, one thing I would like to note over here is that figure 3 is actually taken from one of our control subjects, and this is the actual oxygen saturation-based changes observed in them throughout our paradigm. And what we consistently observed was that between 4 to 80-second mark, we could always see a change in the oxygenation from the breathal stimulus. So moving forward, we use this time point range to for further assessments. And finally, with our selected reference region, we calculated the Pearson's correlation coefficient between that reference, shown here by the black star towards the bottom, with every point on the foot. So right here, what you see right now is the real-time Pearson's correlation coefficient being calculated for each pixel of the foot. And so what I'm showing right now over here are 6 oxygen saturation-based correlation maps from all 3 of our controls, with 1 case provided for the plantar and dorsal side of the foot. Red indicates regions of positively correlated or synchronous oxygenated flow changes with respect to the reference in the black circle here, and blue are asynchronous or negatively correlated changes. And what we found was that within each of the correlation maps, there was a similarity in the correlation ranges. And visually, this can be observed by the relative homogeneity of the coloration in each map. In addition, the yellow to red coloration indicates positive correlations across the foot. Now, to quantitatively assess all of these spatial temporal maps, we calculated 3 correlation maps per measurement and extracted the median value of the correlation coefficient distribution of each map. Using this median gives us a good idea of the central tendency of the distribution in each map. And then we calculated the average of the median value of the correlation coefficients per measurement. This value was used to assess if there was a variability in the oxygenated flow within subjects across repetitions and between subjects. And what we found was that on average, the plantar side of the foot had a typical correlation of 57% plus or minus 23%, whereas the dorsal side was 29% plus or minus 14, indicating positively correlated and synchronous flow. Now, we applied the Kruskal-Wallis one-way ANOVA to determine if there was a difference in the average median of the correlation coefficients between control subjects in the plantar and dorsal side of the foot. And what we found was that there was an insignificant difference in the median of the correlation coefficients by side across the subjects, meaning that controls had similar correlation ranges by side. And so, to summarize for study 1, what we found was that breathal-induced oxygenated flow changes were positively correlated and synchronous in controls. So, moving on to study 2, this RV proof study was conducted at the University of Miami Hospital with 10 ulcerated subjects, 1 non-DFU and 9 DFU cases that were imaged during their regular wound care visit. The same imaging paradigm and processing scheme from study 1 was applied here. And shown to the right now is a concise table showing at which weeks each subject was imaged with respect to their subject enrollment date. Now, each image session was counted as 1 case to assess the oxygenated flow of healing and non-healing DFUs as things can vary between weeks. And of the 38 total cases, those where there was excessive patient movement were discarded from further analysis, leaving a total of 20 cases, 5 non-healing and 15 healing cases. Shown right now are the oxygen saturation-based correlation maps for 1 subject across multiple weeks of imaging, consisting of healing and non-healing cases. The black oval in the center of each map roughly demarcates location of the wound region. And what we observed was that during weeks of healing inside that black oval, the wound region, it was more positively correlated, indicating that the wound had more synchronous flow. But during weeks of non-healing, there was more negative correlation. So the blue region you can see right here in week 6 and week 5 in the wound region that even extended beyond the wound itself. And moving forward, we wanted to look at the median of the correlation coefficient, the median value of the correlation coefficient distribution in correlation maps across subjects. To do this, we used the average of the median value of the correlation coefficient per subject and side of the foot. And for DFUs, we calculated the median value of the correlation coefficient distribution for each case. And what we found was that non-healing DFUs had visually apparent lower median correlation coefficient values. All of our DFU cases had a median of the correlation coefficient that was 20% or lesser. All controls were above it, and 11 of the 15 healing cases were above this demarcation. However, we did find something interesting. Of the 4 healing cases that were below this in a similar range as the non-healing cases, 2 of them had complications. Subject 9 at week 1, during that week of imaging, their DFU was infected. And subject 4, while denoted by the clinician as on the healing side, had very poor healing outcome. In 3-month increments, the subject had vascular bypass surgery to the DFU foot, followed by osteomyelitic bone resection from the DFU region. And finally, after 9 months of effort and attempts, there was a transmetatarsal amputation of the DFU foot, indicating that in DFU cases, those that have lower medians of the correlation coefficient might be at risk for complications during the healing process. And so to recap for study 2, what we found was that controls in healing DFUs had higher median values of the correlation coefficient, indicating greater synchrony of oxygen flow across the foot. In addition, the non-healing DFU cases had lesser values of the correlation coefficient, indicating lesser synchrony in the oxygen flow across the foot. I'd like to thank the nursing staff at the University of Miami Hospital's Wound Healing, Ostomy, and Hyperbaric Medicine for their help and assistance with this, as well as members of the Optical Commissioning Laboratory, and funding from the NIDDK's DiaComp Award and F31 Fellowship. Thank you.